Good afternoon or good morning, whenever you're choosing to watch and listen. Today I'm going to cover different ways that we would score and interpret assessment tools, focusing on how we would document or what we would say when we document those. So our learning objectives, hopefully we understand the different types of scores based on what type of assessment that we're administering. So this lecture is going to go through just a wide gamut of different kinds of scores, and we likely won't use all of these scores, or we likely may not even encounter some of these scores with some of the tests we use, but know that they are options as ways of scoring. Students will derive clinical interpretation of our objective results. We'll identify importance of utilizing central tendency to inform our interpretation of scores. Students will implement multiple strategies to ensure successful documentation. Now, again, this isn't a documentation course. We're merely trying to get you to think like and investigate like an occupational therapist. Documentation will come throughout as you move through the curriculum. So the goal of scoring, again, scoring an assessment tool, we're trying to analyze occupational performance. So we might give a particular assessment tool in order to gather some type of data, right? Hopefully we'll be able to transform what we're observing, maybe an observation of their performance of a particular testing item, in an accurate, defensible, and meaningful way, right? So when we're giving an assessment tool, we're asking them to do something, we're asking our client to do something, we're observing their behavior, and then we may score that, or we may follow procedures to rate that particular observation. Hopefully scoring will contribute to our clinical reasoning. So if we get an objective score on an assessment, we're able to use that score to sort of see if our client qualifies for services, to see where they have greatest challenges with. And so sometimes those objective scores will help us make sense, or will help us make the results more understandable. They'll help us problem solve. If we know specifically what a client is struggling with or where they're having the greatest challenges, it may help us create some of those intervention plans, and also allow us to communicate to other professionals, maybe their physician or referral source, to educators, to other people who need to know about that patient's performance. Some of the real common scores that we'll come across are going to be raw scores. We call them raw scores because we typically simply add up what those numbers end up being in a column. From that raw score, we might also come up with a scale for a derived or an obtained score. Okay, and so again, these are just different types of scores that will probably make more sense when we start covering certain assessment tools, right? And we're calling for certain, or we're having to figure out what some of these scores are. A lot of times your raw scores will be converted then through the use of charts in the administration manual to your standard score. Okay, so they're taking that raw score, they're considering, okay, what's this child's age? Let's convert their performance, their number, their raw score to what that normative sample score is. And they'll help us get that standard score. When we're following scoring procedures, it really helps us with reliable and valid findings. It helps us with appropriate interventions, so we know where to focus and target our interventions. And really, when we're using scores to guide our practice, if you will, or guide our interventions, it really helps us provide more cost-effective healthcare. So different ways, different scores are responded to. There could be different rating scales or different methods for scoring. So with some of the assessment tools that we administer, some of them are going to be based on the observation of the patient's performance. So like for the Peabody example, there's a standardized protocol where what we have to say to a client to have them perform. And then we're observing what their performance is. And then we're guided based on that standardized protocol to allocate a 0, 1, or a 2 score for that item. There are certain checklist scales. And so this might be something like a behavior is listed. And we check, is it present or is it absent? Right? So this might be like a reflex checklist or something along those lines. Is it there? Is it not there? There might be some other scales or checklists, if you will, that have forced choice. And so they may have, or they would have to choose a particular choice, and they don't have no for an option. So they'd have to choose something or the other. The problem when you have people filling out scores, if they write no or not applicable for everything, then there ends up being testing bias there. And those scores don't necessarily help us identify where to focus our interventions. Semantic differential scales. This allows subjective concepts along perhaps a continuum. So this might be, do you seldom, do you frequently, do you always see or experience these particular symptoms? Q-sort is a series of questions into categories. So this might be a list of particular questions you have, and then those questions are sorted based on particular categories. I'm thinking of the activity card sort assessment. It's very similar to that kind of a response. So now when we go to norm referenced assessment tools, these are the ones where we're comparing our patient's performance to that normative sample. And so, or that representative sample. So that sampling that was taken of that typical population, okay? That normative sample. With our norm reference testing scores, that allows us to compare our patient score or individual score against the other test takers from that normative sample. Okay, so more likely than not, we're going to be testing people who likely have issues or likely have challenges, right? And so by testing them with some of these norm referenced assessment tools, we're more likely to say, oh, they're in the third percentile for children their age. And I'll kind of go through later on what exactly that means. But that allows us then to show what percentage of delay they have in comparison to that normative sample. Norm reference testing broadly tests behaviors or abilities. It's useful when requesting additional intervention from third-party payers, right? So we can say, hey, they've made progress. They were at the 2nd percentile for children their age. Now they're at the 20th percentile for children their age. Okay, they're still below half, so there's still a delay, but clearly they're showing progress and we're catching up. And so also, that also helps us justify the need or the medical necessity for OT if we're still finding that they are below that normative sample. Criterion referenced assessments, sometimes referred to as competency or competency-based testing, because usually there's set criteria where you can do them or you can't do them. if you can do them, you're usually successful with a particular domain, okay? And so we can compare our individual results to a particular criterion, okay? So this might be a patient, how are they with their independence and self-care skills, okay, or their basic activities of daily living. And so we might have some kind of a criterion referenced assessment saying, okay, well, to assess basic ADLs, what level of assist do they need for grooming, hygiene, dressing, bathing, toileting, okay? And so if they can do all of those things, all of those criteria on that checklist as a pass, right? Or they're able to complete those, then that test tells us, okay, well, then they're independent with basic activities of daily living. So whatever criterion testing or criterion reference testing, there's usually things, usually steps, if you will, of tasks that they have to do. And then you determine, okay, what's their level of mastery or skill based on these items. Criterion reference testing can be very, very important in helping determine discharge or placement, discharge placement. So using criterion referenced assessment tools, say in acute care, in rehab, long-term care, those kinds of things where patients are wanting to go home, you can say, okay, we're going to give this criterion referenced assessment tool upon admission, and then we can track that over time, not to that normative sample, right? But we can track that over time with our patient and see if they've made progress. And once they've been able to achieve certain items, we can confidently say, hey, they have demonstrated independence with this criterion referenced assessment. Therefore, our recommendations are that they would be able to function at home. Okay, so I use this a lot in acute care, skilled nursing, transitional care, where they really relied on OT to figure out, okay, can this person go home, or do they need to look at a skilled nursing facility placement, or do they need to look at assisted living placement? What's realistic for them? And so by using a criterion referenced assessment, I had that data. It wasn't just based on what I thought, right? I was relying on evidence. I was relying on data from an assessment that guided what my recommendations were. So both types, both norm reference and criterion reference, can be standardized, meaning that there's just standardized protocols to follow, okay? Typically, they have directions for administering, and they may have directions for scoring. Even with the criterion referenced assessments, you might total up a particular score, right? And then that score would indicate, okay, are they at a risk for falls, or are they, do they need assistance with this particular activity of daily living? Therefore, you really need to make sure that you're reading the test manuals before administering, that you practice delivering the assessment tool, that you adhere exactly to the published administration with scoring instructions without deviating or adapting. Again, these assessments that have been published have gone through rigorous studies. They have established reliability and validity. And so we have to make sure that when we use them, that we're using them and following their directions. Convey the importance of the assessment to the clients to ensure that they will do their best, okay? If deviation somehow does occur when administering assessments, in your documentation, you have to report that. And if you're giving or providing that assessment and you don't give the same directions that that normative sample was given, or that that criteria was set with, then our results are going to be skewed, and we won't be able to use our results to compare to other people. Or, right, with criterion referenced assessments, when we go to reassess or reevaluate that patient with that criterion reference tool, we have to make sure that if another therapist is doing that, that they give the same exact instructions that we gave them. I'll talk a little bit more about that coming up. So there are different types of measurement scales. So how we actually, what our numbers mean, or how they're derived, or how they're used. So nominal scales basically is a score that identifies whether the tester has or does not have a characteristic. And so those are, if you can kind of think of, your intro to statistics, right? So if you are, your demographic is a boy, right? You might code that as a 1, right? Or a girl would be a 2. And so we really saw this, I saw more of this where we converted demographics for the home health assessments that we all had to do. Okay, we had to fill in bubble sheets and those kinds of things. So male, female, are you having pain? Yes, no pain, no. So pain would be 1, no pain would be 0. Married, yes, or not married, no. Married would be 1, not married would be 0. So again, you're just allocating a specific number. It might be 0, a 1, or a 2, based on whatever result they gave. The ordinal scale, that rank orders a given characteristic. So there's a level of order to it. This might be tallest to shortest, bronze, silver to gold medalist, low, medium to high stress. You also might find ordinal scales. I think when we looked at one of those screening tools, right? Frequently, seldom, never, kind of going backwards there, but those also have a particular ordered scale to them. Interval scales, that usually is a score that reflects a difference between the responses. So an interval scale might be, maybe we're taking our patient's temperature, okay, or maybe we're doing 30-second timed trials. And maybe we're doing 4 30-second timed trials. And so then each score would be taken at every 30 seconds. And so there should be a difference between those responses. The ratio scales can be like interval, but uses a scale with a 0 for an interval. So you might have 0 as a score, and that would indicate that there's an absence of a symptom, or that it's never seen or never experienced. Something like that also, when you're thinking of 0 as absence of, might be, miles per hour, running speed. If you have 0 miles per hour, you're not running, right? So that would be that absence of. Oh, central tendency, how I love you. I know it can be intimidating, but this really helps us understand how our patient is performing in relation to that normal distribution, or in relation to that normative sample. So when all of the data is taken for that normative sample, okay, it forms this beautiful bell curve. Because right in the middle here, let's see here if I can get my control right here. Yay! Right in the middle here, we have, this is the mean, right? Right in the middle, that line. And what that means is that based on our sampling, most of the population fell right in here, which is why this is kind of a bigger belly here, right? Is most of our participants are falling in here, right along this line. This line is the mean, okay? And so we'll see here under cumulative percent, roughly this mean is the average of our entire population. So that would be probably their 50%. Okay, 50% of the people went here. That's why it's huge. Okay, and then from there, we're going to have our really high achievers, and the further out we go, the less they usually are, right? Because again, this is average. This is what most of our participants were able to achieve. We also have those underachievers, okay? And so, you know, we might have a couple participants maybe who are performing down here from that typical age range. And so that kind of explains central tendency. So typically, and maybe you psych majors, a lot of you psych majors do testing, IQ testing, where you have that standard score or you have that percentile, right? And so you might be used to different types of scores, if you will. Like your mean might be 100, right? And then a standard deviation from that mean might be 15 points, okay, plus or minus. So somebody with well, I'll get into that later, I guess. I don't want to mess this up too much here. But so again, this line is the mean, okay? That's where most of the participants fell, or, you know, most of our participants' scores were. And so that would be a percentile rank of 50%, okay? So if somebody's in the 50th percentile, that means that they're right at the mean, right at average, okay? Now you'll see here too, we have standard deviations, okay? So based on what type of tool we use, that will indicate what our standard deviations are going to be. Now, when I say that, like here we have t-scores, okay? A t-score is 50, it's also the 50th percentile, okay? That t-score is going to be a type of standard score. So we have taken our raw score, we've added up a particular column of scores, okay? We've looked in the chart for the child or age that we're looking at, and we've said, okay, what does a raw score mean to convert to a standard score? So if they had a standard score of 40, if you will, keep hitting the wrong button, of 40, we're going to say that's their standard score. Okay, so what does that mean? What does a standard score of 40 mean? Well, if we look up here, we see that a standard score of 40 would indicate one standard deviation below the mean, okay? We can see here that one standard deviation below the mean is a difference of 10 points. So if somebody had a standard score of 30, they would be 2 standard deviations below the mean. If somebody had a standard score of 20, they would be 3 standard deviations below the mean. Okay. What I also want to point out here is z-scores. Okay, so we see here on this line here, -1, right? That's standard deviation. If we look right below that, we have z-scores. Some of the assessment tools that we'll cover, particularly the BOT2, you will get, or you will be able to calculate a z-score. And so, you know, what the heck does that mean? What is a z-score? Because it's usually a definitive number, like -1.23 or -1.72, right? It's a very specific number. And so what the heck? So we can actually say that z-score of 1.72 is 1.72 standard deviations below the mean. So your standard deviation is nothing more than your z-score, but your z-score is going to be a very, very specific number. That can be really helpful. I know there are some states, some therapists I have worked with from other states, when they have come and worked with me, they have said that their outpatient facility they had to have a z-score of -2 in order for that child to be picked up for OT services. And at that time I was like, what the heck is a z-score? Right. And then I was able to, oh, okay, yep, it's I use the term standard deviation, right? They're using z-scores, which is a little more specific. So we'll talk a little bit more about that, particularly when we get to the bot2. But just know z-score is nothing more than just a standard deviation. It's just more specific number. And again, this could look different. Okay, so this is a t-score. This is an example. For some of our assessments, the mean, right? We have here the mean right in the middle. That standard score could be 100. And then plus or minus 15 is that typical standard deviation. So that's something very typical that we do see when we have a scale like that. But not all of our assessments are scaled that way. So we do have to understand how is our particular assessment scaled so we can interpret that. Because again, if somebody had a standard score of 40 for this particular scale, I would be able to tell somebody, okay, they are one standard deviation below the mean compared to children their age. Okay. So the mean is going to be the average group of scores. And so when we place it on that normal distribution, right, we would, for our example here, we would take 10 plus 5 plus 8 plus 10 plus 7. So that'd be 40. And then we would divide that by 1, 2, 3, 4, 5, because there's 5 total numbers. And so our mean score, if these were our scores, our mean score would be 8. Okay. Our median or our midpoint scores, and there are some assessments where you do figure out the median instead of the mean. This is going to be your midpoint score. So this is going to be, you're going to rank order them. So the lowest would be 5, and then 7, 8, 10, 10. And the median is nothing more than the middle score. So in this case, it would be 8. The mode is the score that occurs most frequently. A mode, so in this instance, the mode score would be 10. Now, I personally cannot think of an assessment that I have used that has asked for a mode score, but I have used a lot that have asked for mean scores, and I have used a few looking at median scores. I talked about this already, but the standard deviation is nothing more than above or below the mean. So if we know that normative sample mean score is in this case, let's say 8, right? Then we're able to compare, okay, our child scored 6. Okay, so we know then that our child scored less than the mean. But how much below the mean did they score? Okay, that's the question. And so we could find the z-score, and so that is a numerical value related to the standard deviation. So if we know that a standard deviation is 1, okay, and they scored a 6, and their median score or mean score is 8, that means they'd be 2 standard deviations below the mean, okay, if that's our scaling. A t-score, numerical value related to standard deviation. So in the example we looked at, a t-score is nothing more than a standard score with a particular scale, right? And so the midpoint is, for a t-score here, is 50, and then their standard deviation plus or minus would be 10 points from that 50. So again, if the assessment we were using was using a t-score as a standard score or a normative score, right? And they scored a 40. Well, compared to the normative sample where the mean is 50, the midpoint is 50, and you minus 10, that standard deviation, okay, to get to 40, That's 1 standard deviation below the mean, okay? Or 1 z-score, or a z-score of -1, since negative is below the mean. If it's +1, that means that it's above the mean. And typically, we're working with children or people that are below the mean. Other scores I think that are helpful is percentile scores. And so this indicates the percentage of norm groups test results below the test taker score and the percentage above it. So a lot of times we'll see percentile scores. Okay, so if a raw score is 15 and we convert that raw score to a percentile score of 38%, we can interpret that for our third-party payers by saying 38% of the children from the normative sample scored at or below the child's score, okay? So this was taken from your Mulligan text on how to interpret percentile scores, so please revisit that and spend some time with that if it's confusing. What basically this is saying is, so we're gonna go to 38%, so this is the normative value, okay? 38% would be right around, did it again, would be right around here. Okay, so the normative sample scored at 38% or below that child's performance. So again, that terminology is just looking at trying to explain where that child's performance was at compared to that normative sample. You might be looking at percentile equivalence too. So this would just be looking at maybe a comparison made only with children in the same grade. Okay, so percentile scores I've used more frequently than percentile equivalences. Stanines, there's some that don't necessarily do percentiles, but they'll take a particular assessment tool, their results, and instead of doing like percentile ranks or normative standard scores, they'll have stanines, right? And so with a stanine, you divide that into 9 sections. Section number 5 is that midpoint. So essentially it's kind of like the mean, if you will. A lot of assessments in education, I've seen them convert to stanines. You'll also have probably age equivalent scores. And so this might be how close the test taker's performance is to patterns from people of a particular age. As a parent of children who have special needs, as an OT who would report results to parents, this is where when you share the age equivalent scores, where it can be misleading to parents and heartbreaking. I'm thinking of, kids maybe have tested who have been on the spectrum, right? Where they're nonverbal, they don't like to follow verbal directions. The third-party payer is expecting me to give a norm-referenced assessment so that I can definitively say this patient's performance is this many standard deviations below the mean for children their age, and it's affecting these occupations, okay? So then when I'm reporting that to the parent saying, the child is 3 standard deviations below the mean, okay? Parents aren't going to understand that necessarily, and so I usually say, yep, there's some, these are some areas with our testing where the child scored where the child scores were lower. Now, this particular assessment is looking at a motor skill, and what I noticed through the assessment was it wasn't necessarily the motor skills affected, but it was more of the comprehension, the following verbal cues, following direction, those kinds of things. And so, I usually have that conversation with parents and then say, okay, so their motor developmental age because they weren't listening and following directions goes down to a 12-month-old level. And, the child's, 6 or 7. And so that can be like, what? My child's performing at a 1-year-old level? What? No, I can't see that. And so if you're looking at a motor assessment, right, and you are using age equivalents, be cautious, and make sure that if you are using them to explain the delay to parents, that it might take the wind out of their sails. And so think about wording that in a more family-friendly way, or helping them understand that only means the developmental age equivalence is only their performance with what we're testing. So for the Peabody developmental motor scales, right, if they're at a 12-month age equivalence, that's what their grasping is at, or that's what their visual motor age equivalence is at. Okay, so it's not them as a person per se, it's that particular skill we're looking at. Testing errors. So we talked a little bit about this already with the accounting for testing bias, but we can find errors in testing if the test taker's fatigued, if they're stressed, if they're sick and not feeling well. Okay. I know I've tested some people or reevaluated some people, and it was the beginning of the school year. It was right after school. And let me tell you, those first couple of weeks after school were really rough for kids, especially kids with challenges, to sort of get into a new routine. They were so tired and so irritable that it really skewed some of our testing results. So I just kind of, okay, we're going to do our re-evaluations before school starts, or we're going to wait until about a month after school starts. Introduced by the test. And so this might be, or errors introduced by the test. So this might be maybe an inappropriate difficulty level. I know with some of the assessments based on the child's age, we start at a particular level. If they don't meet that thing, then we have to go backwards. And so for some of our really severe kids or affected children, we have to, start at that area and then go back and 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 go back in the items that we're administering. And so by the time we get to what they can do, they're so burnt out, or they're so tired, or they're so defeated that they haven't been able to do anything you've asked, that can be difficult. Also, poor wording. So some of the assessments might have some wording that might be confusing to some people, and that's really challenging because again, we're supposed to give, for some assessments, we're supposed to give those exact word for word directions, right? And so we have to really make sure we understand and know what leeway we have, or if we do have any leeway, and how we're wording things or what we're clarifying. Error in administering. And so this might be maybe our improper training, or it might be, I have to do this assessment because a third party payer tells me to, and I think it's silly, blah, blah, blah. And so I might go into it with a bad attitude, and then I might make a mistake, or I might give an extra verbal cue and not mean to, or I might give different instructions than what that normative sample did. So that can have an effect on how I administer. Also, if I just am not uncomfortable, if I'm really, really nervous because I haven't given the standardized assessment before, and I'm not that familiar with it, and then I'm having to look back to the manual, and I'm leaving the child unattended, so I can read the results, or read more instructions, and then I'm trying to pull that child back for their attention. That can also lead to errors with administration. So practice those assessment tools. And that's why I've embedded some of those assessment tool practices in the course to make sure that you guys are practicing. Errors in scoring. So this might be personal bias errors. So, it's I've run into the case where I've maybe reevaluated a child, and I've worked with that child for about 6 months. It's time for the reevaluation, and I've gotten to know them, and they have grown on my heart, and I care about them, and I want them so badly to succeed. And then when I'm giving a standardized assessment and they do something, and I'm like, oh, but I've seen you do that. I've seen you do something similar in our intervention session. I think you could do better. Oh, should I just give them a score of a 2, or but they only performed at a 1? What do I do? And so that's kind of my personal bias, right? And so that might mean that, if I am biased that way and I give them a 2, well, using an assessment tool measures their performance in time, right? At that moment in time. And so what is the reason why they were able to do it in intervention before and they're not able to do it now? Maybe they're stressed. Maybe they're, oh no, I'm being tested. Maybe they're bored. Maybe they're, we can interpret that as part of the assessment results, right? But really that shouldn't affect our score. Their score should be what it is, or we should score them for their performance. Also incorrect response recordings. And so this might be doing math errors, okay? There's math. I'm so paranoid, I'm not good with numbers. And so I, always check and double check my math. And then I go back and I look in the charts and is this making sense? Okay. So when we're controlling errors, and again, we covered this already, making sure we're trained and that we have the qualifications, making sure that we are recalibrating and practicing those assessment tools, right? I remember practicing them, at home, getting ready for bed, and of course I didn't have children back then. And so, I'd sit out on my bed and I'd lay all the pieces of the assessment tools out, and I'd be looking at the manual. I'd be talking out loud to my little dog at the time, God rest his soul. And, I would be saying the words out loud and then going through, okay, so if they got that one, then I go to this area, okay, and then using these words out loud. So, that's recalibration. Seems funny, but that really helps your confidence level and helps prevent error. Making sure we're following standardized procedures, okay? Students tell me a lot of times when they're first giving a standardized assessment, oh, I gave the instructions wrong. Oh no, what do I do? And so, well, next time practice, right? Practice going through them. Practice those scenarios, role play scenarios, go through all of those things. Environmental considerations as well. And so making sure that, we're looking at where we're giving that assessment tool at. Outpatient, where you're in that contrived environment, in a quiet area, pretty sterile, not a lot of distraction, you're going to get a different performance. And sometimes that can be good, right? We sometimes want that, so we can measure that performance at that given time, because that might be where we provide our interventions, and so that will be very helpful for us. Some outpatient therapies are doing evaluations in the child's home to further replicate. Okay, well, if the child's distracted when I'm giving this standardized instruction, that's just as pretty realistic to his home life, and we're going to get a better picture of his everyday functioning in this environment. Okay, so pros and cons to both. I think having your rationale for where you're doing your testing, I think, is important. So steps for scoring, interpreting. Verify the assessment, and is it appropriate? So how? Okay, how would we do that? Well, we would probably be doing an internet search. We probably should be looking at research articles. When's the last one that's been published? What have they found? I would probably first and foremost look for the instruction manual, right? Read in the instruction manual. How have they gone through reliability, validity? Is it norm referenced assessment? Do I need a norm referenced assessment? for the third-party payer, right? Does it actually measure some of the concerns that are brought forth by the caregiver or by the referral source? Once we find whether an assessment is appropriate and we've gone through all of those things, then we actually use that to assess the client, okay? So we're using that for our assessment or evaluation. When we're done with the assessment, we usually want to go through with the client and debrief with them, maybe find out from their point of view what they thought was the most challenging, what they thought, were there anything that they did on the assessment that further explained some of the issues they were having with their occupations at home. When we get those scores and when we hear that from our patient, we should be going back and reviewing the manual. This might be, okay, what do these scores mean? How do I interpret this? Are there charts that I need to look at? So again, that thorough review of the manual, again, to look at, okay, what do I do with these scores? And then from there, you're likely able to document your overall outcome. So what are you wanting, or what are you expecting? What are you thinking would be those appropriate goals? That leads to preparing goals, okay? And so collaborating with the client, making sure they're in agreement with them. And then from once you have those goals, how are you going to meet those goals? What are some intervention ideas? How are you going to work? What are you going to work with your patient on that daily basis? So the thing I want to say about documentation is it's the only permanent record remaining after the services are rendered, okay? So if it's not documented, it didn't exist. I worked with somebody who was the greatest OT I think I've ever worked with, super smart, super energetic, was so super productive. And she would get, patient care, patient care, patient care, patient care. And she wouldn't take the time to document. And so she would have like all of these evaluations, right, that she didn't document on. And she would tell some of us other therapists that we were taking over their care, and she would say, oh, just work on dressing with that person, just work on this with that person. So she was telling us these goals, that she knew the patient needed help with, but we didn't have the actual report to go off of to see what did she test them with, how did she test them, what was their current level of assistance. And so, it didn't take long for her to really get in trouble because, were we providing therapy, were we providing services without an evaluation, right? And again, since there was no evaluation report, it looked like, from a reviewer standpoint, it looked like therapy was being administered without an evaluation. So she was that far behind with her documentation, and it basically was looking like fraud, right? So she got in a lot of trouble for that. And, it's a good lesson that the only permanent record remaining after services are rendered is our evaluation report or is our documentation. There was a gentleman I worked with also who was in a severe car accident. He hit a deer, and his seatbelt had hurt his shoulder really bad. And we were doing, we were treating his shoulder. It was an acute type of a situation. He was in an outpatient, it was outpatient, but I mean, the accident had just happened. He didn't have range of motion. He was having a lot of pain, a lot of bruising, those kinds of things. And so eventually his car insurance was paying for his therapies and medical appointments. And then his car insurance said, why are we doing that? You have medical insurance. And so the car insurance actually sued his medical insurance because his medical insurance, they were claiming, should have kicked in. And so the court subpoenaed all of his documentation, right? And they were going after each other in court. And so, it was really important, kind of nerve-wracking, like, oh, I hope I documented okay. But basically, they were looking at, were the services medically necessary? Was there a medical thing involved or something like that? Because again, they were trying to get the medical insurance to pay for it. So sometimes our documentation can and will go to court. I've worked with therapists who have had to testify just in cases like that with insurance providers. I know some of my children, as a foster parent, a lot of my kids have had PT, OT, speech, and all of their reports and records were sent to the courts as well to look at, what was the child's functioning when coming into care, how have they been cared for, how have they been addressed, how have they progressed in our environment. And so all of those, cases were really important. So again, documentation is very, very important. It's our chance to apply the results. So here are the results, but again, this is where we can add in our meaning, right? Remember step 3 of OT evaluation, when we're analyzing everything, pulling everything together from the occupational profile, from the analysis of occupational performance. Okay, this might be where I also say, hey, this child on the spectrum performed in the 1 percentile for children his age on motor skills. However, right, his true performance may not be, his true performance with motor skills may not have been measured accurately with the standardized test, as his difficulty appeared to be following verbal cues and directions, right? And then I might further explain, therefore, my plan for OT intervention is going to work not necessarily on motor skills, but looking at following 1 to 2 step tasks so he can follow the motor cue or motor skill of face washing. So again, I'm tying it to that occupation, okay? But that's a really important piece. So for my intervention plan, then my intervention, right, I'm not just doing hand over hand assist Legos for motor skills, but I'm tying in that cognitive piece or social piece as well, which is really the heart of the issue. So I have to make sure that in my evaluation documentation that I'm explaining the heart of that data. Again, we're synthesizing quantitative and qualitative data. A report communicates information about the client from an OT perspective and should articulate the rationale for OT. So is it medically necessary? Is it skilled? When I say skilled therapy, can an OT do it? Or does an OT have to do it? Or can the parent do it? Okay, so what are we going to do that's a skilled service that's rooted in OT versus maybe a nurse assistant that could do it for them? Creates a chronological record of client status. So as we're writing down daily notes or progress notes, right, we're hopefully showing, we're leaving a paper trail of the progress that we're making. It sets us up to provide evidence of effective OT intervention, right? And so again, documenting those progress notes, getting that baseline evaluation data, doing a re-evaluation and showing that there has been progress and saying, hey, there is progress here, is just allowing us to show, hey, OT is the bomb.com. We're making progress here with our patient based on our evidence. So there's 4 process or classifications documentation. There's 4 aspects. Process stages, this would be our screening or our evaluation. There's timing types. So there's the initial evaluation. This might be more formative. Their progress evaluations are typically formative, meaning that, our evaluation, our initial evaluation is that baseline data, right? We're getting that formative information. Then our discharge plan, that's going to be more summative. So patient was seen for 30 OT sessions between this date and this date, right? Goal summary or goals worked on were this. This is how we worked on them. This is the progress that the patient made over time. This is where their current function is. This is where they're at meeting their goals. Therefore, right, patient is being discharged as their goals have been met. So your discharge summary is really pulling from the whole time that they've been in treatment, and you can kind of outline and use a summary of their whole OT sessions. Let's see here. So you might have the initial OT eval, you might have progress notes. Again, that's just going to be really looking at progress towards goals, progress they're making with interventions. And then again, discharge is when they're formally being discharged from therapy. Settings and styles. So a medical model, community-based classifications of documentation. Your SOAP notes are going to be really common. And again, you guys will take more about SOAP notes and practice writing SOAP notes. It's just a particular format to follow when documenting. There are certainly other forms. DAP has been one noted, and narrative is also one noted. I use SOAP notes most frequently in outpatient, acute care, transitional care, home health care. The only setting I use narrative in was more so when I go to Peru and it's working in the school system, and we're kind of showing what it is that we're actually doing. We're actually more consultative in that type of setting or role. And I've also used narrative notes more so in mental health and reporting on group participation and those kinds of things. Design format. So we all should be using electronic medical records, but I know there's some facilities where they use little paper checklists, right? And at the end of the week, that's when they do their overall documentation on progress. And so again, electronic medical records is sort of where everybody is at this point. When we're using documentation, realize that the records mean recoverable. So they can be found and used in court or for other recommendations like child custody. I know there's been other things. Youth Social Services has pulled records for kids that I've worked with where, you know, the child's been reunified with a birth mother. The birth mother misses like 10 appointments in a row. So then, you know, we were instructed to call social services, and then we had to have documentation, no show, no show, no show. You know, we had to have documented that somebody called, reminded, left messages, who we left messages with. And so again, make sure that you're documenting. Following AOT's guidelines for documentation. And so AOTA has published just a very general guideline for how OT should document. I believe the most current is 2018. I've requested samples of documentation that are de-identified. And so I've asked other therapists that I've worked with, hey, can I check your patient charts and just see how you documented? And that probably was the most helpful for me when starting in a new setting. There's certainly samples of documentation in textbooks too, so keep that in mind. When documenting, respect the reader. Don't make the reader work. Remember the sample evaluation with the MIN-A and I and the B and the, you know, all of those abbreviations. Don't make them work. Or using acronyms too, like when we do our clinic where we collaborate with PT and OT, and I might be the assigned faculty, and I have PT doing, and I'm pretty good at abbreviations because I worked in rehab for a long time, but I don't know necessarily the acronyms of some of their assessments, or I might know what the tug is, but I don't use it every day. And so I don't necessarily know what it is that it measures. And so again, I like to follow the APA guidelines where I will say the Peabody Developmental Motor Scales, right? And then in parentheses, PDMS-2 is an assessment that measures fine motor, gross motor skills, is standardized and norm referenced. Okay. That way, the reader knows exactly what the PDMS is. And then from there on, I can say, results from the PDMS-2 are as follows: standards, raw score, standard score, normative standard score, standard deviation, percentile rank, those kinds of things. So again, that'll make sure that the reader doesn't have to work. When we switched to electronic medical records, when I wanted to report on an assessment tool, I could click it and it automatically would populate that in. I thought that was the neatest thing ever. But that typically is one of the a big piece of feedback that I give students. Our documentation should always try and show improvement. Okay. Last date of session, they were at this assist. This date of session, they're at this assist. Therefore, they're making progress. Okay, so don't be afraid to document, or don't be afraid to point that out, that yes, they are making progress. Again, that kind of goes with don't make the reader work. When in doubt, leave it out. Okay, explain your jargon if there is jargon, or if there are abbreviations. Use descriptions of the jargon or of certain assessment tools so that you can teach others. Okay, so other disciplines, your physician may be reading it, or the pediatrician may be reading it. And they don't have time to understand our language, and they're pretty good, but they don't always know it. I've had conversations with pediatricians and they're like, gosh, I see you give this bot too. I have no idea what that is. Oh my gosh, you don't know what that is? Well, no, I don't give those assessment tools, but I am relying on you to give them. And so you help me understand what that is. And so, again, what we document can help teach others. You want to use past tense active rather than passive verbs. And so, when I use the word seem and appear, it's saying use them judiciously. I'm saying use them cautiously because they sound wishy-washy. And when we sound wishy-washy, we don't sound professional, okay? Eliminate the word will, would, could, should, because they sound judgy, okay? So the patient should wash their hair. Well, what if they don't want to wash their hair one day, right? I don't need to wash my hair today, do I? I don't know, I don't have any. So again, sometimes the words come across as judgy and a little condescending. Again, when I say judgy, separate judgments from descriptions. And so when I say, use the word appear judiciously or seem judiciously, I'm probably going to add some descriptions in with that, right? Patient appeared lethargic today. He was noted to have his eye closed and, appeared very sedentary, was difficult to arouse. So I'm adding those objective measures in there that explains why I thought they appeared lethargic, okay? Spell check, check autocorrect. Okay, a lot of spell checks don't come up with medical terminology and those kinds of things. I think they're getting better. But again, you don't want to read a professional report, or I would be mortified if a pediatrician or a physician, especially an orthopedic surgeon, received an OT evaluation from me and it was full of spelling errors. I would be completely mortified. In fact, I think I've had nightmares about that. Use readability statistics if available. So again, when readability statistics, 2 standard deviations below the mean, okay? that one I think I used quite frequently, like was between 1 to 2 standard deviations below the mean. So I wouldn't necessarily say the z-score was negative 1.2, but I might say things like they were below the mean. Okay, therefore they tested lower than children their same age. Okay, so again, I might add that explanation factor. You know, adding that little statement would really help a third-party payer who reimburser who maybe has a high school degree. Collect descriptions and databases. And so there might be certain descriptions or certain databases that you use. Just make sure that, you know, and this is more so like EMR. We had little databases in our EMR. Again, like what is the P-body? And so when I click on it, that would populate and go right into my report. We want to make sure our documentation that we're protecting privacy as well. And so again, using EMR, password encrypted computers, those kinds of things, we'll want to make sure that those reports and documents aren't falling into the wrong hands. All right, so that is my lecture on scoring and different types of scores, interpreting, and just general principles for documentation. I'm going to be showing and sharing some about the Peabody Developmental Motor Scales, which is a norm reference standardized assessment. And I'll have videos of my kids that I've used testing them and going through scoring. And I'll kind of flip through some of that. In lab, you will have opportunity to get your hands on the assessment tool itself and hopefully get some practice administering it. And hopefully that's when some of these concepts really start soaking in. So it's okay right now if things seem a little muddled, right? It's broad general strokes of information at this point. We'll be able to revisit some of these concepts as we start exploring some of the other assessments that we're looking at. And so, you know, it might not make sense right now, but when we start getting into the examples, right, we'll try and pull back this information and to recall it. All right, thank you so much.